and welcome to this TCTAP 2022. I'm Giulio Guagliumi from Bergamo, Italy, and I'm co-moderating this live session with Dr. Satoru Otsushi from Osaka. And please, Satoru, introduce our distinguished group of panelists.
Okay, thank you very much, Giulio. Good afternoon, everybody. We have 4 panelists today. So I would like to introduce Dr. Michael Hood first.
Good morning.
Good morning. And Dr. Sung Ha, nice to meet you.
Nice to meet you. Good afternoon.
Good afternoon. Dr. Alan Fang.
Hi, good afternoon.
And Dr. Yubel Kaur. Good afternoon. Good morning, maybe. So let's go into the live case.
Okay, thank you. Good to
yeah.
see and Dr. Giulio Guglielmino and Satoru Ochi and Dr. Her and Dr. Hode and Dr. Upsala Kao and Dr. Wong. And welcome to TCTAP 2022 live case demonstration. We at this session prepared 2 very interesting cases. And the first, my case is less complex. Second case is a much complex case. So I would like to introduce our team and the senior fellow and Dr. Ho Jin Lee. So, okay, Dr. Jin Ho Lee, can you present the patient background?
Yeah, thank you. I'm Jin Ho Lee from Assam Medical Center. Let me show you the brief summary of this case. 48-year-old male patient referred for upper chest pain. So we checked the coronary angiography and the result showed the significant stenosis at the proximal RCA and proximal LAD and distal circumflex artery. And he had no past medical history about coronary artery disease. Next. He had 4 risk factors, which is diabetes, hypertension, and hyperlipidemia. And he is a current smoker with 25 years of smoking history. The clinical presentation of this patient is stable angina. Next. The electrocardiogram showed the basic normal sinus rhythm without no ST change. Next. In chest radiograph, there is no evidence of cardiomegaly and pulmonary edema. Next. And the non-invasive study, such as echocardiography, showed the normal ejection fraction. And let's see the coronary angiogram. In the right coronary angiogram, the RCA have a diffuse stenosis to proximal to mid portion of RCA. And the PA caudal view, the distal circumflex have a short tight lesion and proximal part of LAD has just significant stenosis. And the cranial view and spinal view, we can see the proximal part of LAD have some stenosis lesion to distal left main and have a big diagonal branch. So we evaluate the ischemia, we check the FFR of each vessel. The first RCA FFR showed the 0.81 and beyond the distal part of RCA. Next, and circumflex relatively small and over the distal region, the pressure gradient is 0.1 and that means a negative of FFR value. Next, in the LAD FFR, the lowest value of FFR is 0.77 and major step up in the proximal part of LAD.
So if I'm gonna summarize this patient, and so this is a 47 relatively young patient and the multiple risk factor, hypertension, hyperlipidemia, and diabetics and the current smoking. So this patient, I think angiographically 3 vessel disease, and we are, I think the FAME3 like a patient, and the angiographically RCA shows some diffuse and the middle RCA part 60-70% stenosis. And could you show us the FFR for RCA, the presentation slide? Okay, So at this time, we already checked the R-shaped part. FFR was 0.81. Our threshold was 0.8. We decided to defer the mid R-shaped region. And next one. So, and the distal sock looks like tight in the 70%. We also checked FFR 0.90. And next one. And the LAD was 0.77. Absolutely, I think this patient is very nice representative of phase 3 trial. Angiographically, 3 vessel disease. We checked the 3 vessel FFR. On the basis of FFR, we decide to treat just the mid LAD to the distal main part. So I think at this moment, I would like to hear some moderator and panel the comment is how do you decide this multi-vessel, 3 vessel disease patient? This is absolutely phase 3 like patient.
So thank you very much for introducing this patient that is very well representative of a younger patient with a diabetes. So perhaps a long story ahead to get further progression. So very important for medical treatment and especially now for decision-making treatment. Then is a little bit challenging anyway because it's confronting many different aspects. Let's move to the panelist and ask, for instance, Michael. Michael, what do you normally approach, and do you agree in this strategy? Do you want to know more on these patients?
So, Dr. Hode, you're muted.
Thank you. No, I think this case was very well presented, and I think every kind of information that is necessary to develop a treatment strategy is available. Now, formally angiographically 3 vessel disease, but hemodynamically relevant only single vessel disease. Now, the important thing here is the proximal LAD lesion, which extends to the left main. So I think we need intercoronary imaging to get a little bit more information how much of the disease is encountering the left main in order to then decide how to approach this. But I think the strategy here, independent that it is a diabetic patient, is for me a hemodynamically relevant single vessel disease, and we should treat that as a single vessel disease.
Okay, let's ask to Satoru. Satoru, what do you say about this case?
Yes, it's angiographically like a LAD proximal single vessel disease, but I think that we need imaging check, because if we put the stent, we should determine the proximal age. And this patient is very young, so the stenting strategy is very important for his prognosis.
Okay,
So,
Haron, everybody claim for imaging. It doesn't matter which one we are selecting, is what IVUS, left main ostium is okay. So we are focusing on the bifurcation and ostial LAD. Can we use OCT? Can we use IVUS? What are you suggesting?
My experience with OCT is limited, so I would do imaging, which I'm more familiar with. I'm sure you would do an OCT for this case, but in this case, I would use IVUS in this case. Yeah.
Great.
Okay, so let's move on, and then we will go back with the remaining panelists asking more questions.
Okay, great. So, you know, as everybody know, well, looking at the phase 3 trial, absolutely PCI, the primary endpoint was not achieved compared to bypass surgery. But looking at the phase 3 trial, the mean number of lesion 4.3 and the stent number 3.7, the graft number 3.4, absolutely very complex disease, even though I think PCI group achieved nearly 80% complete revascularization. The editorial comment is focusing on the big region, the main region, the PCI was inferior to bypass surgery do not use the intravascular ultrasound. The phase 3 trial, just 11% use the intravascular imaging optimization. So I think we check the IVUS is how can you decide optimize is very helpful for this case. We already checked intravascular ultrasound HD image. Could you show us the IVUS? Okay, this is the mid distal LAD part. So could you okay, this is the mid part, the most significant region. Plaque started from here. Okay, the vessel size is nearly 4.0. Okay, the plaque, the here eccentric plaque. Here is the prox LAD part. Is a diagonal branch is coming. The diagonal ostium looks okay. I think this is the most narrowest part, and we can see some circular calcification, and the vessel size is more than 3.5, and the plaque is huge, more than 80%. This is the proximal distal limb main. We can see the very huge the amount of a plaque burden, and this is a limb main, the mid shaft part, and we can see the plaque was absolutely extended to the limb main ostium. So I think based on the IVUS finding, we can the guarantees what size is suitable for this patient. After checking of the IVUS, is there any comment? Also, I would like to ask the discussion and the panels and moderate opinion. If you're gonna use the much widely used intravascular ultrasound in the phase 3 trial, do you expect a different result?
Well, I don't want to speculate on phase 3. I wanted to comment on this case and the IVUS pullback you showed to us. Which type of information we got? I think multiple. Number one, there is a huge plaque burden, more than we can see, especially toward the ostium, compared to the angio. Second, there is some calcification, but with reverberation. It means that it's not going to be too much hard to treat this lesion. The risk is more toward embolization compared to underextension. The last information, very important. I would like the panelists to comment. The lesion is going up to the ostium of the left main. You might have still some plaque near to the ostium. So instead to say we are landing mid of the body of the left main, we needed to go a little bit further. So Dr. Ho, do you want to comment on this imaging and any type of strategy?
Yes, thank you, Dr. Guarolini. I think the one important thing is we also need to check that the circumflex, the ostium, because of LAD ostium has a significant disease, and also the plaque is already extended to the left main. So we have to clarify the plaque extension, not only for the LAD, but also for the circumflex. So probably in that case, for my opinion is we have to think about one stent, or if there's some the amount of plaque in the circumflex, we think about the two-stent strategy because of the left main bifurcation reason almost. So also another thing is once we decide to just one stent, the crossover is we have to reopen the circumflex, the ostium. So that's another the important point.
Good. Have you done any type of IVUS assessment of the circ? Have you done already an assessment, IVUS assessment of the circ or no?
No. So we are our team absolutely FFR believer, and the SOC FFR was 0.9. RCA is okay. We decided to just treat the LAD and distal limb main. After stenting, something done, we will check the FFR again, or sometimes we're gonna do intravascular ultrasound again. Is our team absolutely FFR believer?
Okay, now the question was if you have a plaque with this high burden at the ostium of the LAD, why not to check also the ostium of the circ to make a decision about the strategy? Dr. Upendra Kaul, what do you think of that?
I think this is a very good case in which we've very clearly seen the utility of physiology. And we know that the problem is in the LAD, and the intravascular ultrasound imaging has very clearly shown that the plaque, a significant plaque, is there up to the ostium of the left main. So it very clearly shows the limitation of angiography, and intravascular ultrasound very clearly shows that whatever we do, I think we have to come up to the ostium of the left main and distally go up to the region of the diagonal. There is a little calcification, but it doesn't look huge. And I think balloon preparation should be good enough. Coming to the question of the circ, because if you're putting in a stent, you're going across the original circ. The FFR had clearly shown that it was normal, it was more than 0.90. Whether it is going to change after putting in the stent by, some of the plaque going towards the circumflex. In case of that, we could, after deploying it, recheck the FFR going into the circumflex and then see whether it has been compromised to less than 0.8, less likely. So I would go with the balloon dilatation. Is not going to require a very high pressure dilatation, and then go with a stent, and of course, like it has been done here, keep a wire in the circumflex from the beginning.
Okay,
Okay,
great.
please go ahead. We are following you. Come on.
Okay, could you show us the angiogram? And okay, first, okay, this is the spiral view and the circ ostium. I think circ territory is not big, and diagonal ostium is widely opened by IVUS, and the region looks like confined distal main in the added ostium. Next one. So, and this is epicranial view. You can see the distal main, how much significant, and this view is a very nice view. And next one. So, and this is the areocaudal view, and the plaque was absolutely significant in the added ostium and distal main. And next one. Okay, so we put this is a 7 French guiding caster femoral approach, and we're gonna do and pre-dilation. This is 3.5 NC balloon, and the added ostium, there was some circumferential calcium. We tried to crack the circumferential calcium in added ostium. And test one. 오케이, 이걸 조금 더 잘 보이게 하자. 이게 잘 보이려나? 오케이, 테스트. 오케이, go. 6, 8, 10. 오케이, deplete. 오케이, slippage. 면서 해야 돼. 오케이, 테스트. 오케이, go. 6, 8, 10, 12, 14. Okay, deplete.
So while you are working, I'm attracting the attention on the image on the IVUS.
Okay, go.
You can see that
6, 8, 10, 12.
the reverberation behind.
Okay, deplete.
That
This is a 3.5 NC balloon, high pressure balloon dilation, and then we will check the lesion preparation result. Okay, push out. So I think it's a slightly increased lumen. So on the basis of the IVUS, and I would like to the full cover the left main. This plaque was absolutely extended to the left main disease, and I fully cover. Okay, 이거 다 끌려나겠다. 잠깐만. 지금 빼봐봐.
So shall we go around and ask to the panelists and the co-moderator what they think about this lesion preparation? Satoru, do you want to comment on?
Usually this, I was finding we need, I think we need a non-compliant bio.
Camera ready.
Aaron?
Yeah.
요거 서커 와이어가 끄집어놔.
I usually use a non-compliant, but on
여기
this
diagonally.
type,
Okay. Okay, wire was just some.
I usually would use a non-compliant balloon for pre-dilatation, just size it to the standard I want to use to save a balloon, NC balloon, yeah. So I think it looks like the even if it's not semi-compliant balloon, the balloon expanded quite well, and on the IVUS it doesn't show that there's any severe calcification. So I think this is probably enough. I would proceed with stenting after the IVUS.
Michael, do you want to do something more in addition, or you are happy with these results of lesion preparation?
Honestly speaking, the IVUS told us that the lumen size was 4.0 in the proximal LAD. So I would have selected a non-compliant 4.0 balloon for pre-dilatation. We see there is some kind of recoil. So at the end, with a 4.0, I would be happy. With a 3.5, I'm a little bit not so much confident on the result that I saw. In general, I would go for a provisional strategy with a 4.0 stent right now that will receive a pot in the left main with the 5.0 balloon that then potentially will give us a good result. The circumflex, if you carefully look at the circumflex, already there is some kind of change in flow in there. So we have to carefully watch on the circumflex. It's not a large vessel, but we will not get rid of it. And we have to anticipate that in the future, the distal circumflex stenosis will become more significant, and we have to re-enter there in the future. So we need to keep the gate open there.
Okay, so Dr. Hope, you was in favor of checking in the circ, and now it's becoming clear that for the future, because he's a younger man, it's going to be very important to keep open the access to the circ, because the circ has already pathology. Do you want to comment on that?
Yes, because even the circumflex, I know the FFR shows a negative finding, but this is a young man diabetic patient, so I think we save the vessel as possible as we can. So continue to vessel like opening is a very important thing, I think. So keep going to his
스탠 줘보세요.
Okay.
So, okay, on the basis of the IVUS, we decide to put the 4.0 stand, and could you show us the epicranial view and 여기서 한번 체크해보시죠.
Yeah, I think whatever is happening is something which was predictable.
짧게 하면 너무 긴데.
That you're dilating the origin of the circumflex, going across it, and some plaque shift is there, and some reduction in the flow is there, which cannot be totally ignored, has to be interrogated. And I think I would agree to go with a 4mm stent and then do a pot using a 5mm NC balloon and dilate the proximal portion of left main. And I'd like to end up by doing a intravascular ultrasound to confirm the apposition and also to see the vessel just distal to the edge of the distal portion of the stent.
Okay, let's go back to the cath lab. We saw some clear cracks.
So on the basis of the IVUS finding, we decide to put the 4.0 and the 38, the drug-eluting stent. Okay, so test. Would you like to cover the whole segment of the left main ostium? Okay, test. Okay.
So for the left main ostium stent, how about the area of cranial view?
Yes, area of cranial view is best view. Okay, 뒤에 좀 확인하고 test. Okay, distal part is okay. So as the Satoru mentioned, area of cranial view would be best view for the exact positioning of the left main ostium test. Okay, slightly pull back. 자, 테스트. 이제 조금 더 나올게. 자, 여기서 테스트. 그렇죠? 자, 테스트. 자, 한번 찍을게요. 왼쪽. 준비됐죠? 네. 자, 풀샷 괜찮다. 자, 잠깐만 한 번만 더 확인하고.
So Dr.
오케이,
Guagulin,
테스트.
so
Yes.
you just mentioned the pre-interventional IVUS shows some like reverberation and there is some risk
테스트 왜 이렇게 안
of
보이지?
slow flow.
됐다 여기 그제? 자, 고 가자.
Is that right?
I
Okay,
was
6,
saying that the
8.
IVUS shows some reverberation that
오케이.
asking
도미나
for
얼마죠?
a
오케이. 세이브.
variation.
디플릿.
So when you
자,
have a reverberation
엔시블은
of the calcium
Yes.
is not very high, and so you can
4.0으로 줘.
be confident in avoiding aggressive lesion preparation. Likewise,
Right.
in this case was done.
And not the full the classic the calcified reason. This is not the case.
Correct. Oh.
So, and I put the 4.0 and the 38, the synergy stand. So I would like to further the high pressure dilation using non-compliant balloon for optimization. And then we're gonna check again the stand optimization by IVUS again. The distal vessel area is a 3.9. I would like a slightly low pressure, the distal part. Okay. 잠깐만. Booster. Okay, go 6. 7.
So Dr. Bak, what size of the
9.
balloon?
Okay, save. Deplete. Okay, this is a 4.0 NC balloon. 자, go. 6,
Dr.
8.
Park,
Okay.
Dida, may I?
Okay. This is a 4.0 NC balloon.
Okay.
자,
Okay.
deplete.
So in my strategy, the ostium stenting, the post balloon is I should dilate the proximal first
Okay, go. 6,
because
8, 10.
this part may be the elongated.
So I think it's the deplete. Previously, we are just our routine do from the distal to the proximal. Yeah,
okay.
yeah.
But for the
Go.
ostium, I prefer
6,
the
8,
post dilation, the proximal first.
12, 14.
Okay, so
Okay,
the
that is good
suggestion
suggestion. Deplete.
avoid
Especially sometimes the stent elongated into the aorta,
Right.
post ballooning.
6, 8, 10, 12, 14, 16, 18.
I
suggestion.
actually agree with Dr. Sataro that should do the pot first because
Okay, go.
sometimes
6, 8, 10.
the balloon may get caught on the
14,
stent and the stent is
16.
not fully dilated. There may be some
Okay,
shortening
deplete.
of the vessels. Yeah. So I would
약간
do the
컸죠?
pot first. Yeah.
자, okay,
So the
20.
vast majority of the panelists agree that is possibly
Okay,
better
deplete. 됐다.
at the ostium with the
Okay.
post dilation to avoid the slippage of the stent, to avoid the deformation of the stent.
Right.
Going ahead.
Okay, so our strategy is very straightforward. We put the one long stenting on the basis of IVUS finding. We will check the coronary angio over here again. 자, 테스트. 오케이, 나이트 한번 줘보고. 나이트로. 오케이, 한번 찍어보자. 오케이, 준비됐죠?
So right now we
No.
haven't done the pot
자,
because that was a 4.0 balloon.
okay,
So I
spider
think
view. So sock ostium
Yeah.
is slightly narrowed over here. 좀 진하게 찍어보자. 풀샷. Okay, so at this moment we will check the IVUS. So I think a sock ostium there was some narrowed part that if required after stenting we will recheck the FFR. So I'm gonna this moment to check the IVUS from the
Michael
lead
mentioned
LAD to the
that,
left main.
this patient is very young. So how about ballooning in the stent strut for the huge event?
So usually, and I think
Because
I
this
believe
patient already has a left circumflex region, and also this patient is
Okay,
very
good.
young.
go. So
Okay,
I think I would like to emphasize our strategy should be straightforward, and we concern everything. We do everything. You know, so we decide on the basis of our knowledge, FFR or IVUS, which we are decide to our decision making. I think we should follow is our pre-owned decision making. If you concern everything, we should touch all side branch, you know, all region. Yes, this is the mid-added part.
Okay, till now seems good.
Yeah.
Not a huge amount of plaque.
Yeah,
But
fully expanded well. We used the 4.0, the drug-eluting balloon, and expanded well.
You can see the asymmetry of the stent at this point. The more you have a plaque burden and the less you prepare the plaque, the more you have a little bit of eccentric.
Yes.
Now is much better, much more concentric.
Okay, this is the distal main. So we try to cover the whole segment of the lamp main. Might be 2 or 3, would be some protruded, and this is a lamp main is a protruded. Okay, so I think over here we check the coronary angio again. 오케이. 자, 여기서 테스트. 오케이, 이제 찍어보자. 자, 준비됐죠? 자, 풀샷. Okay, I think suck all stem is okay. Diagonal branch is good. 여기서 갈라서 찍어볼게요. 풀샷. Good. And the cranial view.
While you're checking, I'm asking because I'm not sure that we'll have 100% of agreement if to this ostium like it is, if you open up the ostium of the circ. Michael, your opinion, very sharp.
No, I think you need to rewire the ostium of the circ and at least do a kissing in order to open it. And then if you want to be conservative, you look angiographically. If you want to be more thoughtful, you go in by IVUS and see what IVUS is going to tell you, whether there is now a dissection, plaque shift, compression of the lumen there, then you will probably change to a two-device strategy.
Okay, only yes or not. Satoru, do you want to be open?
In this case, considering about the patient age, I would like to open the stent strap for the future event.
Okay, thank you.
So I think we will do that FFR again. So and the second case, much complex case. After seeing the second case, before that we will finish FFR sarcostium and then you know.
Okay. But the recommendation from this analyst is look to this ostium, please. Thank you very much.
Okay, thank you. Great.
I'm Dr. Do Young-gang from Asa Medical Center, and Dr. Ant, my senior, will guide my procedure.
I will assist him.
And our senior fellow, Dr. Jin-Sung Park, will present the second case.
Yes, thank you. I'm Jin-Sung Park. I'm from Asa Medical Center. This case is 57 years old patient. He was admitted for unstable angina. He actually was recommended to do KBG, but he didn't want to surgery. So coronary angiography in other hospitals showed significant stenosis at distal left main and bifurcation lesion. And echocardiography showed normal LV systolic function without regional wall motion abnormality. And he didn't have any previous MI or revascularization. Next. And he has a diabetes and he's an ex-smoker. Clinical presentation of this patient is unstable angina. Next. This is the baseline ECG. There's no definite Q-wave or no remarkable findings. Next. And this is a chest PA. It also no definite cardiomegaly. Next. And this is a baseline coronary angiography of this patient. In right coronary angiogram, there's nearly normal coronary, but some collateral flow from RCA to septal branch was observed. And this PA caudal view, there's some angiographically significant stenosis at distal left main to proximal LAD, and there's quite tight lesion at also of circumflex. And let's move on to further projection. Next. It's quite clear that proximal LAD region and proximal circumflex region, it is bifurcation region.
58-year-old male patient with diabetes with a severe left main bifurcation disease. And there is a very strong debate on the CABG versus PCI in this kind of patient, but we don't have enough time. So the patient refused surgery and we decided to perform PCI. Then how to perform the PCI? So one thing we need is the intravascular ultrasound. The importance of the intravascular ultrasound for left main bifurcation PCI is not enough to emphasize. So next, and because there was some collateral flow from RCA to LAD, so the patient was very stable during the angiography and during the wiring. It's a very fortunate thing. And now, the moderator and panels, do you have any comment or this patient?
Okay, absolutely, yes. Very interesting, very intriguing, especially in this spider view. The point is you have a little bit of a contrast on the left side of the ostium. And the point is what it is this one? Is a calcium? Is a huge plaque burden? How to decide? That is going to be very important. Satoru, what do you think about this image?
Well, maybe everyone agreed we need imaging in this case. So after imaging, maybe the angiographically there's some calcium burden, but we have to decide this character from the IVUS. So we need IVUS is a mandate this case.
Okay, Dr. Ho, you are in love of the circ, and so now is the time. In this case, we wanted to know about the circ, but the circ is almost occluded. In this case, you are preparing a little bit with a small balloon before knowing the circ. Should be done from the beginning. Can we done later?
How you are muted?
허승호생님 muted.
Dr. Hu,
Please.
we are not listening to you.
Okay, sorry. So I think if I were the operator, because of for the safetyness, so I prefer to test the small balloon. After then, I performed the IVUS. Because of it looks like for the spider view, there is a severe calcification, the angiographically, not only for the circumflex, also the LAD. So I performed the IVUS before the small balloon dilatation.
Okay. Upendra, your opinion.
Right.
Lesions are really critical. The proximal LAD as well as the circ are very severe, and I think I would prefer to wire both and do a pre-dilatation with a small balloon.
Right.
Get some flow and then do the intravascular imaging so as to get a meaningful images. It looks, angiographically that there is a calcium in the proximal LAD. You can see on the left side. So we'll see how much calcium is there, what is the arc of calcium, and whether balloon alone is enough or whether we need to do debulking of the lesion before we, decide to put in the stent. So I think pre-dilatation followed by imaging and then deciding what to do, whether to balloon it or to do debulking using a cutting balloon or a rotablade.
Michael, do you agree on this strategy?
I think this is a nice strategy. I think it's important to know how much calcium is there. I'm quite confident that we will come here along with a 2-stent strategy. The challenge is really the mismatch of the vessel size distal to the left main, because you see the left main looks to be a 5.0 vessel, something like that, and the distal vessels are around 3 angiographically at least. So you need to find the right match here. Yes, I think IVUS is, at least I would do IVUS again, is important. Whether you can pass with the IVUS, you can try. If not, you have to predilate with a small balloon.
Okay, let's listen, Aaron, about the angle of the circ.
Yes.
What is predicting in terms of a strategy eventually?
Yeah, the angle is very acute, and in this case, I think the culotte technique may not be a good strategy. So for left main, I almost most of my cases is done by DK crush. The concern here, actually, I agreed with Dr. G that they could be a contrast staining in the plaque there, and it could be because patient present with unstable angina, so the risk of distal embolization is there if this is a ruptured plaque, and also if it's a calcium, this is very eccentric. And if you expand it too big, then it may be pushed in one side. The risk of perforation is there. I think imaging is vital here. Yeah.
Okay, super. You have all our support in going ahead, and let we see what you wanted to do in this case.
Julio, how about supporting device in this case? We don't need a supporting device.
Well, it's a normal EF, so the right give collaterals to the LAD. So I'm not going to use a supporting device in this case personally.
Maybe the small balloon, both direction of the small balloon, maybe supports preserve every function during the procedure.
Okay, let's go back to the cath lab and see what the people in the cath lab want to do.
Yes, thank you for your precious comment. And as you recommended, we prepare the IVUS for image evaluation. And next, and the wiring was not so difficult. Next. And for the safety issue, we prepared a large bore guiding catheter, jacking line catheter, and wiring was not difficult with the Xion wire and BMW conventional wire. Next, and then I applied 2.5. Next, there was a slippage, but now it was inflated with a 2.5 semi-compliant balloon up to 12 ATM. And then we check the IVUS. Next, this is the angiography after ballooning of the LAD and circumflex. Next, let's check the previous, and let's check the IVUS. IVUS run. This is the IVUS from the circumflex and the proximal circumflex. There's a near normal area, and after OM branch comes in, and you can see the balloon-related dissection and hematoma. And at the very proximal part of the circumflex, there was heavy calcification that was eccentrically located. And the vessel size at the normal area was about 2.7. And you can see again the ostium of the circumflex. Let's see, after OM branch comes in, and balloon-related hematoma. And there was some calcified plaque, but I think that it was dilated after 2.5 balloon. And let's check the LAD pullback. I also checked the IVUS from the mid LAD to left main. Let's begin. Here is the just distal to the diagonal branch. Here is diagonal branch came in at 5 o'clock, and the plaque begins. The eccentric plaque is located, and then here is the very tightest portion. You can see heavy calcification eccentrically located at the 11 a.m., 11 o'clock. Yeah. And then here, just the distal left main bifurcation, you can see that the opening of the circumflex from 3 o'clock, and left main, the vessel size is huge, and there are large amount of the plaque continued to just ostium of the left main. So with this finding, we could see that there was some severe calcification. Do you agree? So I want to ask the moderator and panelist.
Good. So somebody was suggesting to prepare gently this lesion with a small balloon to see. And if you are going back when after the pre-dilation, you can still see the incredible asymmetric distribution of this plaque. So Aaron was also in favor to suppose an eccentric tight nodular calcification. It is the case. IVUS images are good. Personally, I think when you are dealing with these things, you can see better by using a different type of imaging technique. But anyway, there is a huge amount of asymmetric plaque calcification. So what to do? Michael?
No, as I expected, there is a large calcium burden there in the proximal LAD. I think it also wraps around a little bit of the ostium of the circumflex artery. So we need to do here a very good lesion preparation. So for me, simple ballooning wouldn't be good enough, even with a non-compliant balloon. So what I would do is here IVL in order to prepare the calcium, in order to make it a little bit more crackable, in particular this eccentric part there. So I would do IVL at least of the LAD to left main, see what we achieved there, and then decide whether I would also need to do IVL in the direction of the ostial circumflex artery.
Okay, so Satoru, there are conflicting data about the value of IVL when you have a huge eccentric nodular calcification. Yeah. What do you think about that?
I have only a small experiment of IVL, but in the concentric calcium cases, IVL is very effective. But in some cases, the nodular calcium lesion, the nodular part not. I don't see the plaque on the nodular part, but some eccentric expansion will be expected in the after IVL.
So, Doctor,
they don't have IVL in not yet.
26.
Today.
Okay, Doctor, your comments on the lesion preparation that Michael said is going to be crucial. How do you want to prepare this lesion, Dr. Ho?
Yeah, actually, in Korea, we do not have the IVL so far, so I have no experience for that. But as Dr. Ojuji mentioned that I think that that's not the concentric calcium. I wonder the IVL is work very well or not, but probably there is some limitation. So, and also by IVUS finding, so the eccentric calcium is a LAD, but the circumflex, there is not the concentric calcium. So that's why the preparation, the balloon has a fully expanded. So I think non-compliant balloon apply is so far my strategy for that.
Okay, Aaron, very interesting. You saw a few seconds ago during the inflation that the calcium is totally asymmetric. Yeah. You have a non-expanding balloon on the left side. So please make a comment on your selective lesion preparation.
Yeah, so I think that what they're trying to do is to deal with the circumflex first and then deal with the prepare the LAD lesion. So for me, I don't think that the IVL would work for eccentric calcified nodules. But you reported some cases it does help. But in this case, I would use a NC balloon, non-compliant balloon to get as much lumen as I can. I don't think that we can ever get a perfect result, but as long as you get a good lumen, achieve a good lumen with stenting, and I will accept that. Yeah.
Yeah, we
Okay.
decided to perform the decay crush, no, not decay, the mini crush technique that we are familiar with there, and implanted 2.75 by the finding of the IVUS, 2.75 by 50 millimeter giant stent, and then next, and then applied high pressure before pulling out the balloon, and next, and further implanted 3.0 NC on previous, further implanted 3.0 NC balloon for maximal inflation of the side branch ostium that utilize the easier rewiring and the balloon passage after crushing and rewiring, and then removed the circumflex wire. Then this is the moment that Dr. Julio said that during the NC ballooning, there was some eccentric calcification was well seen in angiography. And for the dilation, I will do another NC ballooning with a 3.5 and nominal.
So Dr. Gang, what is the stent size of the LAD to the left main?
I'm considering the 3.5 to 38 millimeter stent for LAD to left main.
So one very
Okay.
important comment was done, I think, by Aaron,
24.
was alluding to the fact that in this case, it's very difficult by using non-compliant balloon to make cracks on the asymmetric nodular calcification, and you needed to try to be to accept an asymmetric expansion of the stents. It is important is the lumen. Otherwise, you needed to use different techniques for preparing. Now it seems that the lumen is bigger, but still you have this asymmetric calcification. And we needed to be very careful, because when you have a persistent asymmetric calcification and you insist and you are growing the balloon, you can rupture also the vessel.
Yes.
So it's a very tricky situation. Please go ahead.
Yeah, I fully agree with your opinion. Deflation. 넘어갈까요? 한번 해보죠. 스탠 주세요. Yeah, I'll try to implant the stent 3.5 by 38. This is 3.5 NC that I applied 24 ATM.
Julio, how about the rotablator before ballooning in this case for LAD?
That would be another good idea.
Okay. The point is that the lumen was quite big.
Right.
So in this case, you need a very big burr to be effective.
But we cannot use a big bar in this nodular calcified region, because wire bias is not to the nodule, so the healthy side. So, but using the only small balloon and a much bigger lumen we can obtain by using the rotor.
Test.
So in that case, what size the burr?
This is
maybe 1.5 for the proximal concentric region.
Angiographically, the stent looks fully inflated. And let's check the angiography. Angio.
The distal part has some under-expansion.
Yeah, we need further dilation. 3.5 and see.
So may we ask to have a look in the spider view?
Yeah, okay.
Just to have a look at the calcification, how the stent was expanded in a more familiar view.
Definitely we need further dilation. And let's check the angio. Angio.
Have a look to the ostium.
Maybe that region is corresponding the area coronary view. Stand on the expanded side.
That's on the expansion still. And to avoid the perforation.
But in the very severe concentric region, the high pressure balloon may cause a rupture. So I think
but we evaluated the
20.
population, the size of the vessel, and it was more about 4.0. So if we use 3.5 and see, then that would be not so dangerous.
Only dilates the healthy part.
Yeah.
Right.
Kenny?
Be careful.
Deflation. Okay, I'll take care. Still, there's some resistance to pass. Okay, 20.
20,
Okay. 2.
22.
Okay. Deflation.
So the kind with this mini crush technique, you don't need to do a double kiss or DK.
No, we do not perform the double kiss deflation because first it is a little bit time consuming and the balloon consuming, and then 24. And with the side branch optimization before crushing deflation show the comparable or better result in our lab 24. So we prefer mini crush with the side branch optimization deflation.
Let's see the IVUS
Yeah.
already.
Okay, let's see the IVUS. We just apply 3.5 NC, and that would be not so enough for the left main. So after IVUS evaluation, we'll further dilate left main if needed.
Dr. Gang's procedure is very step by step. For circumflex stenting, Dr. Gang maximized the circumflex stent area. And now Dr. Gang focused on the LAD. So after LAD IVUS evaluation, Dr. Gang will apply the high pressure further to optimize the LAD stent outcomes.
This is LAD prepare from with LAD. And here diagonal osteo, I try to put the stent as intended. And you can see the eccentric plot, how it changed. Let's see. There's some eccentricity.
Yeah.
You can see with the protruding calcium. Yeah.
Even though lumen is very nice.
Yeah.
Yeah.
Lumen size is big.
Also because you saw cracks behind.
Yeah.
So
Yeah. It's the left main.
seems very good.
Yeah. And stent was placed at the just ostium of the stent.
Okay. The entrance of the stent at the ostium.
Yeah. 4.0.
For
high pressure balloon. Yes. We need more more further dilation of the left main, especially for the left main ostium.
What do you think about the results? It seems okay. Looks good.
Looks good, but we need more.
Okay.
But it's dangerous to apply the 4.0 at the prox LAD. But this is just for the left main POC and left main shaft test. Okay, nominal.
12,
This is 4.0 NC, 14, 16,
16,
18,
18.
deflation. Yeah, yep. Yeah, 20. Yeah.
Aaron, any comments on the IVUS results?
20.
Yeah, I think that the lumen looks pretty good in LAD, and it's a bit eccentric. Although the stents, I think I would accept the results. Like I said, mentioned before, I don't think you'll ever get a perfect round results in the.
We are doing our procedure. The Dr. Park at the room number 2 already finished his procedure. So you can go to the another room, and then we'll come back here.
Okay.
Okay. Good.
Okay. So, and Julio, we are finished our procedure. So this is just everybody know remember, and this is some suck ostium, some pinching, some narrow, and next one. So this is area coral view. That there is some pinching and narrowing. As everybody recommend, we check FFR. So can you see the FFR? Okay. As you can see, we are the next one. your coronary angio. This is okay. We are the zeroing and then the locally passed the FFR wire easily well and the passed, and then we checked the FFR. The baseline, the FFR value was 0.75, was compromised. So, and slightly some pullback the FFR at the ostium of suck and going up the nearly normalized. That means suck ostium is severely jailed and narrowed. The FFR was 0.75 and the pullback, the going back to normal. So we are decide to final kissing balloon dilation. And next one. So here we are removed. We just use FFR wire, and this is anchoring, and the next one. And we try to initially the 3.0 compliant, but it does not pass well. We are step by step. This is a 1.0, and then next one. The 3 and 4 time 1.0, and then this is 3.0 compliant balloon, and they expanded well. And next one, sequentially expanded well suck ostium, and then next one, and the LAD 4.0 and the balloon, and the final kissing 1 time 3.0 suck ostium, left main 4.0, and the first kissing, and then the second kissing, and then this is a final view, and we are check the imaging. Could you show us the imaging from the proximity to the distal main? Okay, here can you see the 7 o'clock, and you can see the widely open the suck ostium over here, and the wire is coming the 7 o'clock, and the next one. So, and this is area coral view, as you can see, previous one. Yes, as you can see, much improved than before. And next one. And then we are removed. This is the final shot, and the suck ostium is much improved. And next one. And this is the area coral view. The area ostium is pinched region is much improved, and the angiographical result is looks good. So patient is stable. I would like to finish this case. So I think we are use the imaging also FFR simultaneously, as you know where, and there is a state of art, the PCI, the combining imaging and physiology, and even though it's just a standing crossover, finally we do kissing balloon dilation. This is our final result.
Okay.
Any comment?
Great. Okay, great. It was a super to share with you this case of imaging and physiology guidance in a complex disease. One quick question to everybody. Do you want to finish with a pot or not in this case, Michael?
I would absolutely do.
Okay,
Yeah,
Aaron?
definitely.
Yes, I would as well. Actually, one question I'm asked the panel to see, because the osteolabmate itself, although have plaque, but it's not that disease. Yeah. So I'm just thinking that with this sort of situation, you put the stent to the ostium. Actually, in this case, the stent actually protrude quite a lot outside the left main. So for the next intervention, hopefully it won't come back, but for the next event, it will be very difficult because with the stent outside the left main, so the guide engagement will be a little trouble. So I would just probably just miss the osteolabmate a little bit, to prepare for the next time, so that the next engagement will be much easier. Yeah.
Absolutely, we hope there would be no ISR in the future.
Okay, good. And Satoru, do you want to conclude with a few words also of appreciation for the kind invitation we had to share this case?
A very excellent result. Congratulations. Yeah, and because this patient is very young, so do you have any data of the TCB of the side branching?
Yeah, I think that is a very, very interesting debatable point, and some the physician is recommended the corridor balloon. Is I don't know. We don't have enough data, and so I know in United States that they don't have any DB data. But the EU European country and Julia, do you have some data for the side branch use DB? And that was some issue about the side branch treatment with DB. Do you have any experience?
Okay, they are experienced, but the data are not conclusive in my view. So we still needed to investigate this aspect. That is quite interesting in a case like this one, with a vessel with a circuit that is not very big in size. So seems very interesting. Okay, let's move back to the other cath lab.
Okay, thank you. See you next time. Thank you. Bye-bye.
Nice to see you again. We just applied the 4.0 NC to maximally dilate and keep the safety of the left main ostium. And then we rewired to circumflex with the conventional Sion wire. And because we applied very high pressure at the circumflex ostium, the rewiring was not difficult. And now this is 2.5 NC balloon to open the ostium of the circumflex with the anchoring 3.5, 8, 10.
10.
Okay. There's some strong resistance deflation. Okay.
And
once again, and there.
Be careful about engagement of the
deflation. Okay, let's do it step by step. Okay, 12.
12.
No,
I usually would use a smaller balloon to dilate that one. And,
this is 2.5 that was used before for the first dilation. So I will use the new balloon, 2.0. 2.0. 2.0. 2.0.
Okay, let's go back to Upendra. Upendra, tell us a bit how you want to approach this time, the situation.
I think, that portion of the stent which still seems to be eccentric, there could be a place for OPN balloon, which, the balloon which goes up to very high pressures to, optimize the final result, because it seems to be partly unyielding. So I would personally use a appropriately sized OPN balloon here.
Okay, one point is that in fact the angio showed this level of asymmetric expansion, but the IVUS was showing a completely satisfactory lumen area. So I think that in this case we needed to be based on the intracoronary imaging, and now they are crossing the ostium with a smaller balloon. So Satoru, any comment?
You want?
I think the imaging is very important, because already the stent started cover the ostium. So
yes, this is 2.0 compliant that finally success to cross and inflate the ostium, and we'll apply NC for the final kissing balloon.
just one comment about the OPN balloon. We use it quite often here in our lab, and we realize that if you already put a stent in and then it's under expanded, and the OPN use an OPN, there's high chance that there's a if you oversize the balloon, you get a perforation, because it works as a like an anchored sort of focus force with the stent, you see, like a Scoreflex, you see. So we would now actually try to use OPN before we put in stent to better prepare the stent rather than after put the stent.
20. Depression. This is 3.0 NC up to 22 ATM. And then 3.5, 20, 4. 20. 4. Depression. And the alternative high pressure balloon, and we'll perform the kissing, 8.8. We do not need high pressure for kissing balloon.
So we have 3.5 and 3.0 balloons.
Yeah, 3.5 at LAD and 3.0 at circumflex. Check the result. Okay. Angio. Yeah. Angio.
Oh, great. That's very nice.
I think considering where we were starting in terms of severity of the lesion, diffuseness, eccentricity, this seems to be a very, very good result.
Right.
It was not obvious without a complication to end up at this point, in my view.
Now we finally checked the IVUS for the final result, not only angiographically, but also with the intravascular ultrasound findings. And this edge was clear without significant on the expansion or dissection. And here the proximal circumflex, and now we applied 3.0 NC and the ostium of the circumflex. Well expanded, I think, despite of the very heavy nature of the calcification. And let's check the left main to LAD.
So one more time, do you want to finish with a pot, or you are not using a pot?
Oh, we already performed the kissing balloon for the left main bifurcation. And
kissing?
For the bifurcation, I will not. And for the left main ostium and shaft, if it need more inflation, I will apply further balloon by the IVUS finding. Here is the this is the IVUS pullback from the mid LAD, and as you could see at the previous IVUS, there's some eccentricity with the protruding calcification, but still the lumen gain is enough.
9 and 10.
Yeah, and left main, the ostium. Let's see. As we applied the submanuvar at the left main, but still the left main is well covered of the ostium.
Stent strat is post left main ostium.
Yeah, I agree. There's a little bit stent damage by the guiding catheter at the very tip of the stent. Yeah, but still the whole lumen is fully covered with the stent strut.
I think so.
Yeah,
I think so.
And I think we do not need more.
Unopposed about where the ostium is back to the aorta. Michael, when we claim to do the pot, in fact, in this case, you can see from IVUS that the expansion in the left main was completely symmetric. So perhaps we don't need to do systematically when you are imaging guidance, because there is no deformation in this case. They can claim that is something that can be avoided.
Well, this is absolutely right. If you have the backup of the intravascular imaging that shows you nice apposition and a circular round lumen, then you obviously don't need to do pot in every case.
Okay.
I think this is a very important point. Pot technique is very important for the angio-guided PCI. But if you do the imaging guided PCI, we don't need the systematic pot technique. We just follow the IVUS imaging. There is some suboptimal result. We can apply the pot, but the stem result based on the imaging it's good. I think we don't need a part technique.
Okay, good. I think that we're done. I think it was in time. Share with Seoul. Thank you very much for hosting us. I would like to give you the ball back to Dr. Satoru Otsushi for making a congratulations and for leading these fantastic dual live cases. Satoru.
Okay, congratulations, these two cases. I appreciate your very wonderful result. So please continue the procedure for the patient for the left main and show us the big data for the left main standing, including the imaging. Thank you very much.
So thank you everybody. Thank you to the panelists, Michael, Ho, Haron, Upendra, and thank you very much, Dr. Satoru, and especially to the team in Seoul. Thank you very much.
Arrivederci.